Pulmonary rehabilitation is an important aspect of patient care for the respiratory therapist. This lesson will investigate the history of rehabilitation programs, the goals and outcomes of pulmonary rehab, including program components and patient candidacy, patient evaluation, and treatment intervention. Rehabilitation programs have existed for more than 30 years. The American College of Chest Physicians, ACCP, defined pulmonary rehabilitation and described aspects of care for patients with respiratory impairments in 1974, primarily for patients with COPD and other lung diseases. The American Thoracic Society, ATS, incorporated these into an official position statement in 1981. With the help of the European Respiratory Society, ERS, the new definition of pulmonary rehabilitation is, quote, pulmonary rehabilitation is a comprehensive intervention based on a thorough patient assessment followed by patient-tailored therapies, which include, but are not limited to, exercise training, education and behavior change, designed to improve the physical and psychological condition of people with chronic respiratory disease and to promote the long-term adherence of health-enhancing behaviors, end quote. Current goals are focused on symptom improvement, functional and exercise gains, and health-related quality of life outcomes. The history of pulmonary care started in World War I, treating soldiers with traumatic respiratory complications, and in World War II, American soldiers were instructed in airway clearance techniques. Respiratory therapists were introduced into the multidisciplinary team in the early 60s. Current disease-specific rehabilitation plans include patient assessment and goal setting, exercise prescription and training, self-management education, nutritional intervention, and psychological support. The first step in the rehab process is choosing goals and outcomes. They should be very patient-specific and pertinent to the patient's lifestyle, needs, and personal interests. Goals should be realistic, such as relieve dyspnea or improve oxygen utilization during activity. Four essential areas that require outcome measurements are, number 1, increasing exercise capacity, i.e. strength, flexibility, and endurance to accomplish ADLs, and create strategies to manipulate the patient's environment to improve physical functioning. 2, symptom improvements such as improving dyspnea and fatigue by recognizing early signs and symptoms, decreasing frequency and exacerbations, etc. 3, health-related quality of life improvements such as quitting smoking and drug and alcohol misuse, or improving medical compliance. And lastly, 4, increasing a patient's psychological status by reducing anxiety and/or depression scores, which are measured by a validated self-reporting questionnaire. Slide 5 identifies an example of 4 measurable outcomes, such as increasing exercise capacity and function, relieving dyspnea, improving fatigue, and creating a higher quality of life. Improvements in each of these areas are measurable. For instance, exercise capacity improvement can be measured with a 6-minute walk test showing improved distance and symptoms, or a health-related quality of life improvement may be measured by improved results on the Borg or visual analog scale to measure dyspnea or fatigue, or a carefully designed standard questionnaire such as a St. George Respiratory Questionnaire. The pulmonary rehabilitation programs may vary and be employed in a variety of settings such as inpatient, subacute facilities, or hospital-based outpatient programs or freestanding clinics, physician offices, or at a patient's home. However, each of these programs has similar qualifications for personnel, program components, and patient candidacy. Most, if not all, have a medical director, program director, respiratory therapist, and of course the patient and their family. Program components consist of 1, patient assessment and goal setting. 2, exercise and functional training. 3, self-management education. 4, nutritional intervention. And 5, psychosocial management. Patient candidacy, although most research is devoted to the COPD patient, includes a variety of patients with chronic diseases such as restrictive lung disease, pulmonary hypertension, cardiovascular, and stroke patients. PFTs are not exclusively considered when determining candidacy, and most patients are referred due to disabling symptoms such as dyspnea, inability to perform ADLs, or decreased ability to work. Patients who continue to smoke also have a significant need for rehabilitation, and smoking cessation counseling should be included in the rehab goal. Additional issues that need to be considered for patient candidacy include financial resources and transportation to the rehab facility. Medicare standards are outlined in the reading assignment. Other candidates include those with known pulmonary risk factors, chronic respiratory diseases other than COPD, pre-post pulmonary surgical patients, and those with limited function due to respiratory symptoms that may improve with rehabilitation. This slide shows some of the risk factors for COPD, including smoking, occupational hazards, family history of alpha-1 antitrypsin deficiency, allergies and asthma, poor diet, low birth weight, and periodontal disease. We begin our patient assessment and goal setting with a chart review and patient interview as discussed in lessons 1 and 2. Various questionnaires and functional tests are available to evaluate patient performance, symptoms, ADLs, etc., but the metabolic costs may be used to gauge the endurance and performance level of patients. Each patient activity is assigned a MET level from 1 to 10 plus, with light activities such as writing or eating being assigned a 1 MET and driving and light housework a 2 MET. Very heavy activities such as swimming is assigned a 9 or 10 MET. 1 MET is equal to 3.5 milliliters of O2 per kilogram per minute of oxygen consumption. Once a patient has been identified and assessed, treatment interventions are aimed at improving patient deficits and progress him or her towards their individualized goals. Some of the possible treatments include airway clearance, designed to remove secretions and decrease incidence of respiratory infections, and functional training, which targets the fatigue, weakness, and dyspnea. Airway clearance may be achieved by percussion, postural drainage, or sustained exercise. Functional training includes energy conservation, relief of dyspnea, breathing retraining, and oxygen evaluation and use. Energy conservation may include providing work areas with supported seating, placing equipment that is used most often closer and easier to reach places, locating a table or counter to act as a workstation, putting chairs in multiple areas to allow for rest between activities, and use of adaptive equipment such as shower chairs, wheel carts, or grabbers to aid in picking up items. A dyspnea scale can aid in assessing the patient for level of dyspnea and creating proper treatment plans. The scale ranges from 0, meaning the patient is not troubled by breathlessness except with strenuous exercise, to 4, very severe, meaning the patient is too breathless to leave the house or breathless during dressing or undressing. Once this level is established, techniques such as paced breathing or pursed lip breathing are helpful. Leaning forward, tripoding, is a useful technique for obstructive patients. Other instructions may include educating the patient to avoid breath holding, Valsalva maneuvers, or unnecessary talking during a task. There has also been an increased interest in complementary therapies such as yoga postures and breathing, with various studies showing improvement in dyspnea measured by the visual analog scale. Oxygen use is the last area we will discuss in this lecture. Monitoring oxygenation during any functional training is imperative. Typically, pulse oximetry, dyspnea and effort scales, respiratory rate, heart rate, and blood pressure are monitored during each activity. In general, supplemental oxygen is provided by nasal cannula, but can be offered with a variety of devices including oxymizers, venturis, or transtracheal oxygen. Indications for supplemental oxygen are PaO2 less than 55 millimeters of mercury, or SpO2 less than 88%, or PaO2 less than 60, or SpO2 less than 90% with evidence of cor pulmonale, right heart failure, or erythrocytosis. Oxygen may be delivered by an oxygen concentrator, which provides up to 5 liters per minute, a portable oxygen tank, or a liquid oxygen system.